you very much, Carol, for your kind introduction. Am I clear? Is my screen is okay?
Very good.
Okay, all right. So thank you very much for the kind invitation. I'd like to extend to both MND Malaysia as well as Singapore and Indonesian society as well, right? So we're going to dwell in the topic of sleep. And of course, sleep is a very lengthy um, discussion and talk because, you know, sleep is very important. Even person who's not deceased, we do sleep. And sleep takes roughly about 1/3 of our lifespan. So there's much talked about sleep, but in particular today and this afternoon, I'd like to talk about sleep in MND and ALS patients. Okay, let me see. All right. Okay, so I'm free from encumbrance. Okay, this is where I was trained. I was trained in Sir Charles Gardner Hospital in Perth, Australia. All right, and I was also a little bit affiliated with the Peron Institute, where it is part of the Queen E Medical Center within Sir Charles Gardner Hospital, where we discuss sleep-related issues with our colleagues, neurologists from the Peron Institute, whereby we sit and discuss regarding sleep disordered breathing, as well as the other sleep related disturbances amongst their patients, right? So now a little bit of the background. I'll be talking a little bit about sleep disturbance and several features in sleep study. Later, very quickly, I'll just go through a few things that we will look at while we're doing a sleep study for ALS patients. In the sleep disturbance part of it, I'll touch a little bit about muscle cramps and fasciculations, a little bit about immobilization, nocturnal pain, restless leg syndrome, and periodic relief movements in sleep, and parasomnias and insomnias. May sound a little bit intimidating, but I will explain to you what is that all about. All right, a little bit of background. I think this is a little, we all know what is this society is for, right? A motor neuron disease society. We know that what it caters for. We know who are involved and who are the people who are involved in taking care of these patients, right? And we know it's a progressive disease. It is unfortunately not a curable disease. We know that it manifests as muscle weakness. It comes with severe disability, and eventually patient will succumb. The prevalence is roughly about 1 to 3 cases in about 100,000 population. It doesn't choose who it wants to attack. The age is roughly between 65 and 70 years of age, and there seems to be slightly preponderance among men, but it actually depends on the age, and it's commonly sporadic. Very rarely we see familial cases too, right? Let's talk a little bit about muscle cramps, right? Normal people, we also have muscle cramps, right? But it is very debilitating for patients with ALS to have muscle cramps, right? And especially if it occurs at night. Why? Because it disturbs the sleep, right? And we know that it predominantly affects the lower limbs, and the prevalence is quite high. It's in the range between 45 and 92%, right? And we know that it is quite common among the ALS patients with spinal disease manifestation, right? So why it occurs? Because there's some excitation which takes place in the anterior horn cell or the motor units, and there has been some electrophysiological discharges at a frequency of about 300 hertz, right? That's quite fast, isn't it, right? So what happens is that these discharges, it kind of like spontaneously ceases after an active stretch. That's why they say that when you have a spasm, when you have some cramps, just stretch a little bit, right? And you notice that you may get a bit of relief. But the problem is that how to stretch a limb which is already weak, right? How to stretch a limb which is already weak. So that is the predicament in patients with ALS. And you know that it is not much of an issue for us people, right? But for those who have got ALS, it becomes burdensome, right? And of course, whenever we see and uh, and and go through uh, these patients, wherever we are, we have to actively ask them whether this is of a burden to them or not, right? So the muscle cramps, as I said, it could be due to a couple of other reasons as well. The other reasons could be due to some electrolyte imbalance. For example, let's say you have problems with the calcium, magnesium, phosphate, right? So you may want to consider looking at those as well, right? And to look at whether the patient is actually dehydrated, right? It'd be good that if all these underlying problems, if it could be corrected, then probably there's a fair chance that these cramps can be tolerated. So the other causes why it can occur is because of some medications like statins, which can induce them. So look into their drug charts and see whether any medications causes them to have these cramps. As I said, stretching may improve, but of course, I don't have much evidence to back it up, right? Mexiletine is a drug which may be tried, but of course, there's no guarantee in it. Other drugs like baclofen, memantine, vitamin E, they all, to some extent, have been used, but unfortunately, they have not shown to be very, very effective. Quinidine, I'm not sure whether you guys are aware of this. Quinidine is a drug that he used to treat malaria, right? It kind of worked for non-ALS conditions with the moderate evidence, and it can be used to treat muscle cramps, but quinidine has got a lot of side effects, especially on the heart. So that's why the usage is kind of like can be used at a very low, shorter period of time with a low dose. So, and fasciculations is caused by degeneration of the lower motor neurons. And of course, this has always been reported to disrupt sleep, right? So let's look at the other cause of disturbance. How about immobilization? Okay, so physiologically, when you go to bed, when you sleep, like it or not, we change positions, right? Normally, it's been estimated that we change roughly about 1.6 times per hour, right? On an average, a normal person can do it, right? But those who have got reduced motor function, right, causes difficulty in changing positions, right? Positions to perform comfort movements, to adjust the bed clothes and all that. So it becomes really, really difficult for them, right? And that really impacts their sleep quality, right? Nocturnal discomfort and pain causes dependency on caregivers. So you can imagine what they go through when actually they are on the bed, right? They may look to you as though they're lying down very peacefully and all that, but when they go deeper in the sleep, where there is a need for you to change your posture positions, that's when the trouble starts. And when you can't do it, and that disturbs your sleep. And if you don't move for a certain time, like for example, I said 1.6 times per hour, you have a risk of getting skin lesions. So that is one of the reasons why you may need to move. So when we notice that when there is the motor component for ALS becomes more depressed, and there is a very higher risk of these patients develop bed sores and pressure sores, right? Okay, previously based observations that intradermal collagen density in sacral sore is increased in ALS, but now it is thought that they are at equal risk. Initially, we thought that probably something is actually saving them from getting a bed sore in ALS patients, but I think it is not really that true, right? So let's look at nocturnal pain, right? So now, why do you get the pain, right? So pain and sleep quality are mutually intertwined, right? So pain disrupts sleep, agree, right? You can't sleep with something nagging over you. You can't sleep when you have a dull ache. You can't sleep when something's like pulling or cramping, or I mean, like something's crawling up and all that. And at the same time, impaired sleeping also promotes the occurrence or exacerbation of pain, right? You become just too edgy, right? Let's say you don't get good sleep, and then you feel that at night, you feel that, oh, okay, I just can't sleep. But then again, hey, there's some, how come my back is painful? How come there's something like, crawling up and all that? So if you look at both ways, pain disrupts sleeps, and impaired sleep also causes pain, all right? Acute or recurrent pain may be due to muscle cramps, as we elucidated, if I elucidated earlier, spasticity or immobilization, right? PMAs, progressive muscular atrophy, makes joints and bones vulnerable to pressure, right? Most certainly, right? And of course, the pains can be divided into few kind of pains classification, right? We have the nociceptive pain, we have the neuropathic pain. So the nociceptive pain actually is a pain where if you ask the patient will be able to point it directly to that area. This means it's very localized. And of course, the cause or mechanism is always known. For example, let's say if they have a wound, that particular area, or they have burnt their skin or scald, so they'll be able to localize that area of pain. And that's known as nociceptive pain. Whereas neuropathic pain, it's actually burning, tingling, or lancinating kind of pain. It can occur spontaneously, and this aesthetics is if it's invoked by tactile stimuli, which means that there's just a hyper uh, painful feeling that they get by just a tactile stimuli to that particular area. So these are the neuropathic pain, right? It's burning and tingling and lancinating, right? This is quite common among diabetic patients as well, when they have nothing's wrong with their feet, but then again, they have something like, burning or pricking them from the foot below, right? And of course, another kind of pain is central sensitization. And this kind of pain potentially occurs in ALS MND patients. And this pain is characterized by a diffuse, it's non-neuropathic, and it's almost permanent, and obviously inflexible by nociceptive trigger. So it just gets exaggerated by nociceptive triggers. Let's say you just touch it, it can get this aesthetic type, and then it just becomes overwhelmed. This kind of pain is known as central sensitization, right? So this kind of pain is abnormally enhanced nociceptive response within the CNS, the central nervous system, right? It is actually triggered by central amplification of non-painful sensory inputs instead of clear manifestation, clearly noxious stimuli, right? So we don't know much about this of this kind of pain frequency in ALS, but some are affected and extremely difficult to treat. I'm talking about the central sensitization pain, which is quite frequent among the ALS patients, right? The reason why, because we don't have much studies, and treatment recommendations, they're unable to differentiate between these pains, or whether it's daytime or sleep-related pain, right? So basically, if a person comes to you and explains this to you, uh, we don't have much experience in treating these pains, and basically it is just based on clinical experience rather than evidence-based guidelines, right? We don't have much evidence-based uh, guidelines on to treatment of this kind of pain. So if you look at it, when you have this pain, nociceptive, when you have neuropathic or central sensitization kind of pain, it is something that be very easy to treat, but of course it needs to be addressed, uh, and it's based on the clinical experience rather than evidence-based. Nociceptive pain may respond to both adequate preventive measures. For example, let's say you encourage them to have increase in positional aids, for example, like paracetamol or ibuprofen. But mind you, these are short-term benefits. Uh, we don't encourage to use this on a long-term basis, but because we know these painkillers, they can affect both your gastrointestinal system as well as the kidney system, right? If the patient encounters intractable pain due to advanced disease, opioids may be added, especially if respiratory, muscle weakness, and dyspnea is present. The opioids we are looking at would be synthetic opioids like tramadol, or probably you may want to consider adding a very low dose of morphine, right? Cannabis proves effective with additional anxiolytic properties, sedation, and appetite enhancing features. So you may want to try cannabis if it's legal at your practice. We have other painkillers like gabapentin and pregabalin, alpha-2 gamma, and tricyclic antidepressant should be considered for neuropathic or central sensitizing pain. This can also be considered. So now the question is that when the patient comes to you and tell that they have pain, it is imperative for the clinicians to know what kind of pain it is. Sometimes it will be quite straightforward, sometimes it may not be, and thereafter you need to consider the painkillers that you can afford to give to these patients, right? Spasticity may respond to central muscle relaxant, right? For example, like baclofen and tolperiston. And again, as I said, they are not without any side effects and they can be tried. These compounds, however, they have a sedative effect, and it will be good to start these in the evening because at least they can have a good night's sleep due to the sedative effect, right? So pain is very common among ALS patients, and most likely it will cause sleep disturbance, right? Both pain and sleep disturbance, can you imagine, is double whammy, can actually impact quality of sleep. And in advanced disease, they predominantly determine the interest in assisted suicide. This is actually something that we need to consider, right? And it is very unfair for a patient suffering from ALS to give up because of intolerance to pain and sleep disturbance. So these things need to be actively sought and actively asked for, right? And adequate pain relief, it is mandatory, right? We have a pain score, analog of visual pain score, that we need to constantly ask the patient how they feel about it, and we have to take it very seriously, right? Impact of pain on sleep quality should always be so diligently, right? Okay, so I'm going to go a little bit on RLS and PLMS. Okay, RLS is restless leg syndrome, and PLMS is periodic limb movements in sleep. It may sound a little bit alien to you, but it is quite common. So RLS, how do you know whether the patient has got RLS or not, right? There is no uh, uh, imaging, there is no blood test that we can do to actually say that the patient actually has got RLS. But how do we diagnose RLS, right? So restless leg syndrome is defined by these 5 essential criteria, right? 1, do you have an urge to move your legs, right? So do you have this all of a sudden when you're sitting down quietly and notice that you have the sudden urge to move your legs? It may be an unpleasant or a painful sensation over the lower extremities, right? Do you have those or not? 1. Number 2, the onset is usually during rest or inactivity, right? Thirdly, it actually worsens at the end of the day, especially in the evening or night. And if you voluntarily move your leg, you feel really good after that, right? If you, let's say you have the urge and you start moving your legs, you really feel good after that. And of course, these symptoms cannot be explained by any other conditions, right? These are the 5 things that uh, will actually allow you to think of RLS, right? So how common it is? It is roughly about 10% in the general population, right? 10%. And the severity may be considerably mild symptoms to profound until it can impair a person's quality of life and also sleep, right? And so if it's about 10% among the general population, we notice that among the ALS patients, it is much, much higher. It can go as high as about 14 to about 25%, right? So that is another reason why when these patients come to any clinicians, be mindful to ask them about RLS, right? And RLS in ALS were reported had shorter history of complaints. Okay, now, so what is uh, why is it the shorter history of complaints? Why? Because the way it occurs in ALS as compared to a general population is a little bit different, which means that in ALS, the onset can be very fast. So within a couple of weeks, for example, whereas in a general population, it may be there until someone notices it in a couple of months, right? So that is what I'm trying to elicit here, right? Supports the notion that progressive immobilization puts the ALS patient at the greater risk of getting RLS, right? So if the patient is progressively, can you imagine if the patient is slowly getting immobilized, and of course, one of the criteria to diagnose an RLS patient is if the patient moves the limb, they feel good about it. And if you can't move it because of immobilization, so I can imagine how the ALS patient actually gets a relief from RLS, right? So the severity is associated with the motor impairment. The worse the motor impairment is, the worse the severity of RLS. And ALS patients with RLS had more difficulty to turn in bed. Of course, because they are being non-mobile or immobile, right, on the bed. So how would they want to relieve the RLS if you can't turn uh, in the bed, right? So why it occurs? Some postulate that mild involvement of the sensory nerve fibers or neuropathic fibers actually contributes to RLS, right? There's some postulations, right? And of course, these symptoms should always be actively sought, as an effective treatment could be offered to these patients, right? So not to forget to ask the patients or the caregivers be alert whether your patients have got RLS or not, because potentially it could be treated, right? So what are the things that we need to look for? As a clinician, you may want to look for iron deficiency, right? You look at serum ferritin level. So you may have to do some blood test. And if the patient has got reduction in the serum ferritin level, so now serum ferritin is also an acute phase reactant, right? If you have any concurrent infection going on, then it may not be wise to do a serum ferritin because it will be abnormally high. So in clinical stability, which means that the patient has got no infection, no fever, no inflammation whatsoever. So for ALS patients of this time, you can do a serum iron, especially serum ferritin level, and look at it and whether it should be treated. If it's low, of course, you need to give them supplements or iron IV iron preparations to increase or to improve their iron content within the body. The usage of dopaminergic medications, for example, like propirenol and pramipexole, these two drugs, which is quite common among Parkinson patients, may be required to establish, but you may require to establish a diagnosis of RLS before starting the patient on these two drugs, right? Starting these two drugs, they do have some side effects using these drugs. It's got a very funny side effects. This drug especially causes someone to be compulsive gamblers, yeah, or sometimes increases hypersexuality in a person, and especially a Parkinson person. And so I'm not sure whether they have, definitely I think they would have the similar side effects if you use on a patient with ALS as well, right? The risk of augmentation needs to be considered. Augmentation means that the worsening of symptoms, right? The RLS symptoms gets worse if you start on this medication, but this is known as augmentation, right? So when you have augmentation, so you may want to consider stopping the medication, right? Especially when you use pramipexole or ropirinol. If you think that there is a risk of augmentation or the patient shows augmentation, then you need to consider stopping it, right? You may consider other drugs, like for example, gabapentin, pregabalin, as a first-line treatment, right? And of course, if the patient has got both RLS and chronic pain, one may need to consider opioids, right? So the PLM, however, periodic limb movements in sleep, right? So how do you diagnose this? So you diagnose PLM as when you do a sleep study, right? And it's defined as, it's actually an index, which means that you have to divide that by a number, and if an occurrence of 5 movements per hour, it is considered associated with words. Anything less than 5, it's allowable, right? But in ALS patients, if they have PLM, anything more than 5 is considered to have worse prognosis for ALS patients. But for normal general population, the index about 5, it conquers the diagnosis of PLM. Periodic limb movements index, if it's more than 15, as I say, it's very common in ALS as compared to general population, right? So now, we don't have much study on this actually. These indices did not provide further reports whether PLM had an objective sleep disturbance or not. So you see, when we do a sleep study and we get the data that the patient has got PLM, right, periodic limb movements in sleep, we also will look at whether it actually causing any arousal, causing any disturbance to the sleep or not. Only if it does, then we can clearly say that the PLM actually causing sleep disturbance. But if it is not, then it's quite difficult for us to judge that whether the PLM actually causes any sleep disturbance. But however, I've noticed that the PLM, as even in the general population, cause some form of an arousal, which actually at the end of the day, when they get up in the morning, they have unrefreshed sleep. So unpublished data suggests that PSG is polysomnographic based cohort study in ALS shows a mean PLM index of about 24, and 1/3 of the patient has got a PLM index above 15. So what they're trying to say is that it is very, very common for ALS patients to have PLM, right? So which means that there probably is a need for us to do a sleep study or polysomnography for patients with ALS, right? So PLM has got no correlation with ALS FRS, functional rating score, right? So this is the rating score that we use for patients with ALS, but unfortunately, the PLM has got no correlation. So whether this actually has got any bearings on functional rating scale, we are not really very sure, because the study for this is really scarce. Whether it's got any impact on sleep efficiency, as I said earlier, because the arousal index is only about 3.6, I'm not very sure either. And whether it has got any bearings on N3 sleep. N3 sleep is actually a slow wave sleep. When we do a polysomnography, whether it's got any bearing on that, not too sure either. So if there's any researchers out there, it will be a great idea if we can do a polysomnography on all our ALS patients and to collect this data, and probably it gives an opportunity to analyze them and to see whether this PLMS has got any bearing on the sleep efficiency and also an N3 sleep. The exact prevalence of PLMS in ALS is not really reported. And of course, when it's not reported, so we are not very sure the PLMS and RLS, they coincide or not, right? So just to give you a rough idea, RLS occurs if you're awake and PLMS occurs if you're asleep, right? RLS, restless leg syndrome, occurs when you're awake, especially during the evening time. Remember the 5 diagnosis criteria that we used earlier. And of course, PLMS is during when you are sleeping, when we have to do a PSG to diagnose this, right? So unclear whether isolated PLM actually are clinically significant or not. But of course, this is something that will be really good to research upon, right? And pathophysiologically, whether PLMS in ALS, is it because a spinal cord disinhibition or hyperexcitability caused by degeneration of inhibitory descending pathways? We are not sure either. All right. So I'm just going to move on to parasomnias. Very quickly, I just want to tell you what parasomnias are. So just bear with me. These are the abnormal movements, behaviors, perceptions, or emotions which arises from sleep or while getting or falling asleep or while waking up, right? So these are the abnormal movements or behaviors. I wish I had a video to show you how it occurs, but I'm very sorry. Probably in the later future, when I have the opportunity, probably I'll be able to show you some videos on exactly how Very interesting to see how patient actually moves in their sleep. And I'm sure your spouses would have told you, hey, I saw you walking during your sleep, or I heard you saying some things in your sleep and all that. So that is all known as parasomnias, right? So maybe regarded as dissociated sleep state, and is characterized by partial arousal from REM or non-REM sleep. REM is rapid eye open sleep or non-rapid eye open sleep, right? If I can go a little bit further, sleep staging, we have like four stages: stage 1, 2, 3, and stage 4. Stage 1, 2, 3 is known as non-REM, and stage 4 known as REM, right? There is no evidence to support non-REM parasomnias are frequent in ALS. Neither is sleepwalking, confusion arousals, or power nocturnus, right? That is a term that we use, especially when you have this kind of like, a very weird kind of expression on you, right? Especially when you're asleep, right? Trust me, it actually occurs, right? And another, these are all, this occurs during non-REM, but a particular interest in RBD, or not, or what you call as REM behavior disorder. This is characterized by persistent phasic or tonic muscle activation during REM sleep. So what happens during REM sleep is that our muscles goes into atonia. Atonia means very flabby or flaccid. Nothing moves when you're in REM sleep. The only two things which moves during REM sleep is number one, of course, is your eye movements, because it's also known as rapid eye movement, the eye muscles. And number two, so diaphragm in the lungs, right? Only these two things moves when you go into a REM sleep. However, in patients with RBD, we notice that they have other muscles which starts moving. This is something abnormal, right? All the other muscles, or any group of muscles should not be moving. How do we detect it? We do an EMG, especially in a sleep study, and we also have what do you call a video EEG. We can record, and when we able to know that the patient actually had gone into a REM sleep, and we notice that patient is also moving at the same time, yes, that's when we can say that the patient may have an RBD, right? REM behavior disorder. All right. So this occurrence may be due to non-functioning of the special pathway, which normally is being blocked during REM sleep. RBD is manifested as dream or enacting behavior, and it may pose as falls and injuries, right? So if our ALS patients actually notice that to have any injuries, we should not forget to ask them regarding how it occurred, whether they had any falls or otherwise. This RBD is strongly associated with the neurodegenerative disorders, like, for example, Parkinson's disease, Lewy body dementia, and a multiple system atrophy is another disease, right? RBD is associated with alpha synucleinopathies, which have been extensively confirmed, or what you call as tauopathies, like anti-LG-LON5 disease. So to have this anti-IG-LON5 disease, you must have an RBD symptom, right? And a small proportion of idiopathic RBD patients may go on to develop Alzheimer's disease or overlap dementia. So if this occurs to our ALS MND patients, you may need to think whether they may have any other concurrent disease as well or not, right? Quantitative evaluation of motor activity during a REM sleep requires standardized analysis of EMG tracing for both upper limb and lower limb. And of course, the existing literature that we have is we have very, very scarce on RBD in ALS patients, right? And they can occur in a small subset of patients. And if it occurs, treatments indicated. And the reason we want to treat it because we want to try for them to have good sleep without any sleep disturbance, and of course to prevent injuries. So there is we must make sure that sleep disordered breathing is not there for patients with RBD. Why? Because sometimes they do. If an RBD occurs in a patient with ALS, I would certainly want to look for whether the patient also has an SDB or not, sleep disordered breathing. That's when we need to correct the SDB by virtue of NIV. Later, Dr. Ian will be telling us about how to treat SDBs, right? The medications like clonazepam and melatonin may be tried for this kind of patients, right? I'm almost coming to the last, but before I go on to the sleep study, talk a little bit about insomnia. Everyone has got, to some extent, some kind of insomnia during our sleep, but let's look at particularly in patients with MND. It is defined as chronically non-restorative, which worsens daytime performance, right? Just imagine if you don't sleep for 24 hours and you try to perform the next day. Wow, that's going to be madness, isn't it? Yeah. So it also causes sleep disordered breathing. It causes pain, muscle cramps, and restless leg syndrome. This one insomnia causes all these. There are two types: sleep onset insomnia or sleep maintenance insomnia, which means that you have difficulty in going to sleep or falling asleep, or after falling asleep, when you get up, you find it even more difficult to go back to sleep, right? That's what this tool is about. Immobilization likely to impair sleep quality, of course. It hinders the patients to turn around in the bed, and of course, can you imagine they if they have pruritus, they can't scratch, can they? Because they're immobilized, they can't scratch. Can you imagine you have something itching down at your extremities and then you can't do anything about it? Do you think you'll be able to sleep well? Of course not. You definitely have insomnia, right? Insomnia is extremely common among ALS patients, and of course the prevalence is not known. Maybe also be present due to stressful cognitions, like due to anxiety, due to fear, and all that. They can also have insomnia. Benzodiazepines, some opioids, undoubtedly they've got role in symptomatic ALS patients, but this should be given especially when it comes to palliative care in terminal illness, right? Usage is indicated if the respiratory failure is present. I'm talking about benzodiazepine on opioids. You can use it if the patient has got respiratory failure present and mechanical ventilation is not consented for, or is not feasible, and is likely to be terminated by patient's will. So what I'm trying to say is that if, let's say, patient is coming to the terminal phase or a palliative care kind of, then of course the role of benzodiazepine and opioids undoubtedly it plays a role, right? But it should not be considered as sedative, as all-purpose medication for insomnia earlier in the course of disease. Try to use this at the later part of the disease, not an early disease. As someone, when you start giving them benzo and opioids much earlier in the disease, they may perceive that as palliation already, right? So we don't palliate the patients early. We palliate only in terminal phase occurs, right? Of course, sleep disorder breathing needs to be addressed, and if benzos and opioids are given in much earlier for insomnia ALS patients, SDB can get aggravated, right? So SDB, sleep disordered breathing, should be diagnosed first in these patients before we start giving benzos and opioids, because the SDB could get aggravated. So of course, the ongoing challenge would be to regularly investigate the causes of sleep disruption and pain. right? Okay, so I'm coming to a slide screen just to tell you some of the features if I do a sleep study on these patients, right? So if you notice that this is a hypnogram, right? We can notice that this black thing over here, this represents REM sleep, right? As I said, we have N1, N2, N3, and REM, and this is wakefulness, right? And you see these are the hours, and notice that earlier part of the night, especially at 12 o'clock, the patient goes into a REM sleep, and then later in the morning, 3 o'clock and about 5 o'clock, right? The other thing I want you to pay attention to the CO2, actually. This is what we look at for patients with ALS when they do a sleep study or PSG on ALS patients. The CO2 actually goes up. The carbon dioxide actually goes up. Anything above 55 is considered to be abnormal. It started off very low, very nice, and notice that after the patient goes into a REM sleep, the CO2 actually kind of fluctuates and goes higher. All right. So another hypnogram, if you notice that the sleep fragmentation, you can see lots of jagged edges marks around here. So this is actually the sleep stages in that person, and notice that how much of disturbance has taken place instead of a smooth line like this. And you can see very short REM. The REMs are very, very short, right? So this is known as the sleep fragmentation. And the N3 sleep is only about 13.3%. The REM sleep is about 6.1%. And a normal adult, you should have roughly about 25% of N3 and at least another 20% of REM sleep. All right. Over here, we notice that the apnea-hypopnea index, right? It's about 83 per hour. What it represents is that the patient has got severe obstructive sleep apnea. Normal, it should be less than 5. And we notice that CO2 is about 54. And of course, anything more than 54 is supposed to be pathological, right? It should be less than that. And another thing is that after the treatment with an NIV, non-invasive ventilator, a CPAP machine, we noticed that the initial jagged, if you noticed that earlier, do you remember? So we noticed that on treatment, the patient started having a good REM sleep, good REM onset, not too much of jagged edges. You notice that, right? Substantial increase in N3 and REM sleep, right? And apnea and hypopnea index, you can see there's only like one event to a couple of events over here instead of 83 events we saw it earlier, right? There's an improvement in saturation. That earlier one was about 80-something%. Now it's improved to about 91%. All right. And of course, we notice that there is an improvement in the CO2. So these are the few things we look at when the patient actually has a sleep study done on them. All right. So that comes to end of my talk. Thank you.
Yeah, so thank you for joining today. So I'm going to talk about non-invasive ventilation, and this is where I practice. Currently is at the University of Malaya Medical Center, a tertiary center situated at the heart of Kuala Lumpur, 10 minutes just right from the Twin Towers of Kuala Lumpur, if you can see. Yeah. The content of my talk basically today, I divided into a few parts, maybe 1 or 2 slides on ALS and the presentation. I think a couple of weeks ago, Prof. Nortina itself has actually given a very comprehensive lecture with regards to ALS and how this disease itself manifests. Then after that, I'll go on some explanation about NIV, what is the component of it. I will also go into quite detail on MAS, the other name for its interface, the stages of initiation, how do we initiate NIV, and complications of NIV, what are solutions, and last but not least, I'll end with 1 or 2 slides on something new, especially over this part of the world for telemonitoring on NIV usage. So for ALS per se, basically is a progressive neurological condition that we know. Okay, that there is no known cause for it, and largely because ALS occur due to degeneration of the upper or lower motor neurons. And ALS occur mostly late middle age, and median onset is roughly around 60-year-old, predominantly occurs in male. And the median survival, it's around 3 years. And most of the patients of ALS do develop respiratory failure because their respiratory muscles are weak. In the past itself, providing mechanical ventilation or life support for these patients were deemed to prolong suffering and death of these patients. But recently, because of the available evidence that we have, the non-invasive ventilation especially has been demonstrated to improve survival and quality of life in patients with ALS. Now, in terms of manifestation or symptoms, I'm sure even the carer or the patients and our medical staff, the doctors itself are very well aware of the typical symptoms that patients will come in, like weakness of the limbs, weakness of the legs, yeah, and probably some bulbar symptoms as well, feeling choking or maybe change in the voice, yeah. But the main, some of the main symptoms that is rather unrecognized to the general public is autopnea is one. Autopnea basically means that the patient may feel a little bit breathless when lying flat. The other thing is sleep-related symptoms. For instance, like feeling sleepy in the morning, feeling unfresh, feeling tired, very poor sleep quality. So these are rather unrecognized symptoms that we are referring here. And it's been demonstrated that only 20% of patients with ALS are actually aware of these symptoms. And when they reaches a level where they feel breathless, even not on exertion, it actually is at a stage of late manifestation that we call it, right? In terms of when patients with ALS are being seen by doctors, doctors normally will try to examine and evaluate some of the findings that they can see in patients with ALS is obviously weakness of the muscle groups. They do have weak cough as well. And if the respiratory muscles is weak, sometimes they use accessory muscles, meaning that because the muscles that supports breathing are weak, right? So they sometimes use these additional muscles to help to breathe. For instance, the neck muscles. Okay? The other thing is sometimes you do see paradoxical abdominal movement. The meaning of this is when the muscles are relatively weak. In a normal subject, if you look at the diagram below, on inspiration, that means taking a deep breath in, the chest and the abdomen will rise together. But because the muscles are weak, especially the diaphragm, let's put my cursor here. This is the diaphragm, which is a major muscle involved in breathing. So the involvement of this muscle will lead to the diaphragm being retracted up, and so the abdomen will be retracted in instead of going up. So it's a opposite of what the normal patients show during inspiration. And 5% of the patients with ALS normally do come with some form of cognitive impairment. So to simplify things with regards to respiratory doctors like me, when we are being referred patients with motor neuron disease or ALS, the main thing is we normally look at muscle weakness, okay, or the diaphragm weakness. Then we also would like to assess the bulbar muscle. The bulbar muscles, that means dealing with phonation, speaking, swallowing, or protecting the airway, the upper airway patency. Then we also will look at the third thing in terms of cough impairment in the patient. Sometimes if your muscles are weak, it will lead to a very weak cough. And this is a major concern for us because weak cough will lead to secretion retention. And patients with ALS with secretion retention subsequently can cause lung infection. Yeah. The fourth box is actually sleep related, which has been presented by Dr. Raymund. So when patients with ALS has muscle weakness, basically it's related to muscle strength, and with this muscle strength involvement, it leads to abnormal lung function. One slide on lung function testing. Basically, for ALS patient, we do get to see a lot of abnormalities when we subject them to a lung function testing. And it has been demonstrated for ALS patient, okay, on average, there will be a decline in the lung function. That means the drop of the volume of the lung, approximately 3.5% each month as the disease progresses. So what we normally do as chest physicians or respiratory physicians, apart from checking, if you look at my cursor, this is the volume of the lung. We call it vital capacity. The other thing is we check the muscle strength, the inspiratory pressure. That means the patient is asked to take a deep breath in, and we check the strength of the muscles. It can be done either through the mouth, inspiration through the mouth, we call it MIP, or sniffing through the nose, yeah, we call it SNIP. So, and these are the ways that should be used to evaluate patients with muscle weaknesses, and also that we suspect has an impairment in the lung function, because by using clinical evaluation, just by asking patients the symptoms wise, are you breathless, are you out of breath, the studies have demonstrated that easily we can actually miss out 50% of patients with ALS who already has some form of abnormality in their lung function. Okay, one slide on hypoventilation that I think is also a major concern with patients with ALS. Hypoventilation basically means that breathing too shallow, and because of this very shallow breathing pattern, the patient is unable to meet the oxygen demands of the body. So when the oxygen levels are low, because the gas exchange is low, logically, there will be an increase in carbon dioxide, right? And with the increase in carbon dioxide, the blood acidity will also increase. The effect from this, there's a few effects for this. On the very surface, it can actually cause some hormonal disturbances. For instance, like your glucose, the sugar metabolism. It can also cause some neuronal changes, like let's say increasing the heartbeat, increasing the blood pressure. It can also cause some effects in the blood vessels. We call it vascular. That's the medical term for it. So in terms of, let's say, the oxygen levels are low, if you look at the cursors that I'm pointing out, low levels of oxygen will cause the narrowing of the vessels. So with this narrowing of the vessels, there will be increase in pressures in the vessel, which is what led to a condition that we call pulmonary hypertension. And this condition is something that we would not want to happen, because with pulmonary hypertension, it will lead to swelling of the right heart. Okay, you see this enlargement, which is swelling of the right heart chambers. Some symptoms that we can look out for if we suspect patient have hypoventilation, such as feeling lethargy, feeling tiredness, feeling sleepy, or maybe out of breath. These are the symptoms that the patient can come to us. Okay. Now let's talk about NIV. The reason behind, or the evidence behind NIV is being used is because of from the studies itself, the effect of NIV, how it helps patients with ALS who has respiratory issues. Number one, by using NIV, non-invasive ventilation, it actually helps to unload effect. It unloads the CO2 levels. Okay, it helps to reduce the loading of the pump. The pump is actually the lung in patients with high CO2 levels. The other thing is it increases your ventilatory stimulus. Yeah? That means it helps to improve ventilation. The third thing is it helps to improve lung compliance. Lung compliance basically, in a simple term, means that the strength of the lungs. So the evidence behind it has been demonstrated that non-invasive ventilation helps in survival of patients with ALS, but is subjected to the non-bulbar dysfunction group. For both bulbar and non-bulbar, it helps to improve quality of life. It also helps to improve the cognitive function of the patient, and it also helps to improve lung function. These are all studies that have been demonstrated the benefits of NIV for ALS. So to make things simple, the optimal time to commence on NIV based on three. Number one, when doctors evaluate patients with ALS, they will ask symptoms that I mentioned. Number two, they will be looking for evidence of carbon dioxide retention. Number three is on lung function, whether your lung volumes or the muscle strengths are impaired. So these three things, any of these three is present, then there is an indication to start on non-invasive ventilation. Right, so for non-invasive ventilation is under mechanical ventilation that we understand. And so the history itself, one slide on it, it goes back to 1950s or 1960s during the polio outbreak over the West, okay, in the West, where at that time, patients developed breathing issues, so there were times that they require chambers like this where the patients are being put in, and this is what we call negative pressure ventilation. The negative meaning that the chambers itself is helping in the ventilation from external, But as year goes by, due to the evolution in ventilation, now we are using positive pressure ventilation. That means either through non-invasive, through the mask, or through a tracheostomy tube, or patients in the ICU through the endotracheal tube. It's a positive pressure that is ventilating the lung. It's very much different compared to the negative pressure ventilation that was practiced many years ago. Yeah. Some major elements of this positive pressure ventilation I've listed down here. I'll be going quite surface one by one. I'll try to make things simple for understanding. For the ventilator itself, there's two pictures you can see side by side. All right, the pictures on the left here these are the basic BiPAP machines that is in the market, whereas the one on the right side is the higher end home ventilators. Right, so the difference is number one, the home ventilators definitely are, they have more features, they have more modes of ventilation. The power source itself is also different. The BiPAPs itself normally requires AC power to operate, whereas the home ventilators does have internal battery. Some can actually last up to 9 hours, and the latest models can actually last up to 18 hours, which is quite long lasting. The ventilators itself, the basic models, they are driven by a blower, whereas the high-end ones, sometimes they are driven by a turbine. And with that, these home ventilators definitely can sustain for prolonged use. So if you're requiring round-the-clock ventilation, then it's better to get machines like this, and rather than just simple BiPAP, because simple BiPAP, the blower itself will get damaged quite easily. Yeah. In terms of oxygen blending, there are some connectors or tubing that you can connect your oxygen to your ventilators if it's required, right? Okay, something a little bit more complicated here, but it's important just for understanding. I just like to bring your attention to two things here. So imagine this is our cycle of breathing in and breathing out. Okay, so the flow goes in and then goes out. So trigger means that it's beginning of inspiration when the patient breathes in, right? And when the patient breathes out, the flow itself, when it starts to reduce, and this is what we call the machine itself will go into a cycling. So cycle so that the next cycle of respiration can happen. So two terms, yes, trigger and cycle. So in terms of your BiPAP, okay, or your home ventilator, sometimes one of the basic mode that they have is spontaneous breath. That means the inspiratory pressure is slowly dependent on patient. The patient takes a deep breath in, the patient triggers, and cycle also it depends on the patient because it's spontaneous, right? Time breath, that means it's everything based on the ventilator, yeah? On the setting that is set by a doctor. And this mode is rarely used because it's not all the time comfortable, yeah? Because the patient has to follow the settings that's set by the ventilator. So a lot of times for ARS patient, we do use assisted breath, meaning that the breath is initiated by the patient and cycle off by the ventilator, right? So something that to help in your understanding, I have done it try to make it simple for you. Useful ventilator parameters for caretakers and patient, it's also good to understand this. So if you look at the ventilator monitor, you do see something written down there or display out called VTE. It's actually a tidal volume. In simple meaning, it's called volume that the machine detects on every breath when the patient exhales. So it's volume. Minute ventilation is total amount of air when the patient breathe out in 1 minute. Okay, total amount of air. So the volume of air that the patient breathes out in a total of 1 minute. Respiratory rate is your number of breath per minute. So the peak inspiratory pressure is the highest pressure in the chest and the circuit. So why is VTE and MV important? Is because minute ventilation through the formula is tidal volume multiplied by respiratory rate. So for instance, if an individual is taking in 0.5 liter of air each breath, and the patient has 10 breaths per minute, so that will equivalent to 5 liters per minute. That is the minute ventilation, right? Okay, circuit, I won't go into very detail because some of these slides I've prepared for the next session as well. I will bring your attention to single limb, passive, or we call it vented circuit, because the two circuits are mostly for ICU machines and doesn't apply so much for home ventilation. So for single limb circuit, okay, there is something called vented or non-vented. So I want to bring your attention to vented circuit, which is the one that is commonly used and simple for home use. Okay, if you follow my cursor, this is the ventilator and this is the circuit, one single limb, right? So one circuit, it goes to the patient and supplies ventilation through a mask or through the tracheostomy, right? This is the circuit that the air goes in. Now, when the air goes in, there should be another circuit for the air to come out so that the carbon dioxide can be washed out, right? So there is where if it's applying a mask, you have something called vented mask. Vented mask means that on top of the mask or somewhere in the mask, there's some small holes to allow the air to escape. For a non-vented mask, which is most of the time is you have a blue elbow like this, then you will there's no small holes to allow the CO2 to be washed out. Then you need additional adapters, things like this, exhalation port, we call it, to be fitted before the mask. Okay. For tracheostomy itself, this is before the tracheostomy. This is also the port itself is also the site where the CO2 can be washed out. Okay, the common exhalation port that you see your home care provider will provide you is either this or the swivel valve. Okay, yeah. So in terms of mask, is there a best mask, or how do we decide on which mask to use? Of course, masks have a lot of concerns, especially leaks, whether how good the mask deliver ventilation, and so on and so forth. The discomfort or the complications from wearing a mask that I'll go into in a few slides later. So I just would like to bring your attention and emphasize this. Yeah, throughout my years of practice, we need to really sort out the interface, because interface is the major issue for non-invasive ventilation use. Actually, the settings on the ventilator is not something that is as, I think it's, to me, the mask is really important, because if the mask is not sorted out, there's a lot of leak, there's a lot of discomfort, it will definitely haunt you and it will turn into a lot of problems faced later. Yeah, so mask is a big issue. So these are some examples for the masks available in the market, and you can see these are newer devices here. Yeah. The first one is a pillow mask. We call it the pillow here. You see the pillow going through the nose. This is the full face mask, or another term we call it oral nasal. Oral means mouth, nasal means nose. It covers the whole thing. This is the old or conventional oral nasal. This is just covering the nose nasal mask. And this is, you see, this is the vented mask with the vented properties here. And this is a quick release for the mask. This is a strap, and this is the knot for adjustment as well that you have on some of the masks. Okay, this is also a oral nasal mask in different sizes. This is a pillow again, and this is another new type of mask. We call it nasal under the nose, where this part actually sits under your nostril. Yeah. So when comparing with different types of masks, right? Basically, if you are deciding, or your home care provider decides to put you on a nasal mask, important is the nose have to be patent, right? If there is a blockage or there is some issue with the nose, then it would be better to consider an oral nasal mask, right? The benefit of using this nasal mask is it allows speaking. Okay, it's easier for speaking, and of course, if your patients really prefer the mask to be small, for him to easier to cough at night, then you want to consider a nasal mask. For the oral nasal mask that I'm referring to, right, and also this nasal mask here, there's always a concern of pressure source on the nasal bridge if the mask is being applied too long. But based on studies that have been done, comparing all the type of masks that I've shown here, the clinical efficacy in providing ventilation is similar. Yeah, so the take-home message is choose a mask that is comfortable. Yeah, is comfortable. Efficacy-wise is similar among all. Okay. So in deciding a mask, when I practice, most of the time, if I am doing mask fitting for my patient, I ask the patient, are you claustrophobic? If the patient says he's claustrophobic, I choose a smaller mask. If the patient is mouth breather, I will choose a mask that covers the nose and the mouth. Sleeping position, if the patient tends to sleep at the side, then I will choose a smaller mask so that it won't get in the way. When the patient turns, it won't fall off. Facial habitus, I look at the nose. If the patient's nose is big, then probably a bigger mask to cover both is possible. The chin and the beard, why is it important? Is because some people who has a receding chin, there's no lower chin over here. If you put them on an oral nasal mask, there's no place for them to sustain the mask can actually slip off the lower jaw. Beard itself can cause, can affect the sealing of the mask between the mask and the skin. So it causes leakage. Dentures itself is the same. So if some of your patients do wear dentures, they remove it at night, it can actually cause the mask to slip off down to the lower jaw. And I use the size chart as well to look at the size that fits my patient. And I let my patients choose what type of mask they actually prefer, whether it's silicone. The silicone sometimes will be cheaper, it's lighter, but the problem with that is they are less durable. Okay, for the gel mask is more heavier and it's more long lasting. It provides a better seal. Okay, some brands have actually come up with this memory foam cushion. You can actually inquire this through your home care provider. They have lots of masks available nowadays. All right, here another picture. This is, you don't have to memorize this. This is just to illustrate the component of the mask. You have tubing here. This is tubing. This is a headgear. This is a headgear, right? And these are the cushions, all right? And this is the frame. And this is the fitting guides or the gauges that I refer to. You see, there's once you measure on the patient's face, you can decide whether it's size L, size M, or size S that suits the patient. Okay. So tip for mask fitting, what I normally do is I try to use a smaller size without pinching the mask. Try not to tighten the mask too much. Subsequently I have a photo to show, but it's the best way to help to determine the strap. Okay, how much to tighten the strap. So adjust the headgear or adjust the mask. You can do it through the strap or the knobs that I've shown you. Cushion or mask should not be crushed against the face. Yeah, this is so important. Caretaker have to take note. Sometimes you have a domestic helper. You need to teach them the tightening of the strap just nice to touch the skin and not crushing the mask against the face. And very important, do not block the exhalation port that I've elaborated in my previous slides. Okay, the exhalation port is where the carbon dioxide washes out from their circuit. Okay, and try not to direct the exhalation port towards yourself or the patient's or the bed partner, because that can actually disturb the sleep. I normally try to do mask fitting when the patient is sitting up, and I try to, once they're comfortable with it, I allow them to lie flat, turn on the machine, get them adapted to. Once they are fine and comfortable with the mask, for caretakers itself, or caretaker who wants things simple, I try to, there's another way of marking the head strap so that every time we put on the mask or the mask itself, the caretaker knows how tight or where is the location of the strap. The strap should be at. During removal of the mask, I sometimes encourage them to use the quick release clip, which I'm going to show later. And I do a fit mask. Fit mask and strap is important. This is a way of wearing mask that I'm going to show later as well. And I do a leak test. Yeah, leak test also I show later. So this is what we call fit mask and strap. Now for all types of masks, hold or put the mask first. Okay, you see, put the mask first. After this, then followed by the strap. Okay, mask first, followed by the strap. Mask first, then you follow by the strap. Okay, not the strap and the mask. Yeah, so this is important. Before we go into those leak tests and things like that, I just want to highlight, this is the alarm from the ventilator. I know caretakers or patients tend to get very worried because of alarms. It's very technical. Sometimes we don't expect them to know every little detail, but just 2 alarms that I think is worthwhile having some knowledge of it, because it's good to know. So one is the low pressure alarm. One is the high pressure alarm that your machines will be set on. What is meant by low pressure alarm is when your volumes are low. Okay, volumes are low. That means either the machine is not supplying the volume enough for your breathing, or something is happening in the circuit. So when there's a low pressure alarm, how to troubleshoot is we look for leaks. So these are the causes of leak, whether it's from the mask itself, whether it's from the tracheostomy cuff, if the patient is on tracheostomy, it could be from the circuit, okay, circuit itself. So the common ones that I've highlighted in red, for instance, the mask. The mask is the major problem, all the time. Sometimes even though you have fitted it nicely, due to wear and tear, it can cause crack. Sometimes the gel or the silicone has some crack in it. It can cause leakage. The tracheostomy cuff is also another one that is commonly causing leaks, especially sometimes sometimes it's not fully inflated, or the pressure drops, the cuff it's not really inflated much, then it can cause leakage. So this two is the common one. Then for high pressure alarms, meaning that there's some blockage, somewhere there's some blockage that is not able to supply the ventilation through. So things that for caretakers and for family to troubleshoot is like look for secretions, look for malposition of your tracheostomy. If the patient is on tracheostomy, check the circuit, okay? And if you have checked through everything and there's nothing found, then probably the patient is unwell. Something is happening in the lungs. Maybe patient there's a collapsed lung, or there's a very bad infection, things like that, okay? The common ones are highlighted again is red color. Yeah, secretions and water. Water sometimes, because of this is an active humidification. Sorry, I just ignore just concentrate, because we're talking about single limb, right? So the blue circuit here, this is the active humidification. That means humidify the air. So sometimes if the level is too high, you do cause a bit of condensation in the tube, and that leads to water trapping in the tube that can actually cause this blockage. Yeah, so back to the 3 stages of initiation of NIV. I normally will explore the patient's will and the level of caretaker the patient has, right? And the level of social support, because that's important. After that, I'll explore the age of the patient, the nutritional status, the limbs involvement. Sometimes if they are too weak to wear their mask themselves, then you need a caregiver to help them. Bulbar function is also something that's really important, because if the patient has severe bulbar involvement, bulbar weakness, right, they may not tolerate NIV so well. Yeah. Cognitive function is also another thing, because if the patient is having some dementia, a lot of movements, also like what Dr. Raymund said, if the patient has some parasomnias, that means a lot of movements or dreams during the sleep, it will tend to be a little bit tricky and challenging for you to treat the patient with non-invasive ventilation, especially on the mask. Sometimes the patient will remove the tube, sometimes the mask will come off. It will lead to a lot of ineffectiveness of ventilation. So these are the things I normally assess. When to offer NIV, I have actually explained earlier on, so I won't go into detail. Now, how I normally start is I start with low pressures. I put the strap on, I talk to them, I try to build confidence with them. Then I slowly increases the pressure a little bit. Okay, while doing that, try to direct their attention off the machine. I talk to them about these concerns on the right side. Sometimes it's done by our home care providers. It's not me, because not all the time I'm free to do it. So they will brief the family or the patient about how to turn on and off the machine, where is the humidifier, cleaning of the machine, the filter, how frequent the machine needs to be serviced. Then go on to talk about the interface, which is the mask, the leak, the noise, the tubes, address to discomfort, any discomfort that the mask can cause. Then we roughly explain about the ventilation part. We ask the patient, are you okay? Can you breathe in comfortably? Can you exhale out comfortably? We address to leakage. Is the air too dry? Is the air too hot or too cold? These are all comfort things that we should, I will explore with the patients, okay? Because if it's not done properly, it will be a major issue later. Yeah? Okay, complications. First, air leak. So for non-invasive ventilation, okay, there is two types of leaks that we should know. intentional or unintentional. Intentional is the one that is coming out from our exhalation port that I mentioned. It allows to clear the carbon dioxide. The unintentional one is, for instance, like your mask is off the face, there is leakage from your circuit, right? There's an unintentional leak. So the problem with this unintentional leak is because when you have leakage, so the flow will drop. Okay, imagine the flow will drop. And when the machine itself detects the flow is reduced, it can trigger, okay? It can trigger and it can cause, once it triggers, even way before the patients finish breathing out, it causes a lot of asynchrony. That means the patient and the machine cannot synchronize. Imagine if there's no synchrony, then ventilation will be ineffective, okay? And that's going to be quite difficult for the patient, right? It will disturb the sleep of the patient, and it can also disturb the sleep of the partner. Imagine the patient turn and tossing around in the bed. Yeah, leaks itself can cause noise, and sometimes it can cause eye irritation. I've seen with my patients complaining to me the eyes is watery, eyes is red, because of the leakage from the mask. The air is blowing on the eyes the whole night. So some solution is simple, appropriate mask fitting. Okay, appropriate mask fitting is the fundamental thing. Of course, you've got other solution like your NIV can actually provide. You can say the NIV can actually provide some form of leak compensation. Not to worry. Yeah, you can actually, if you're using a nasal mask and patient is breathing through the mouth, the leak is from the mouth. You can use things like chin strap as a strap to help to tighten up so that the mouth would not open at night. So if your patient's having beards or dentures, these are some things that you should look into. Foam pads, sometimes the leak comes up from the nasal bridge. These foam pads can be applied so that the cushion itself is nicely fitted on the patient's skin and reduce the leakage. Okay, so these are some pictures and a video to show some patients that I encounter. Okay, maybe just start this video. Sorry. Okay, so this gentleman, after sleeping for 1 hour, so unfortunately, this gentleman is in the ward, so I went and see him. He was taking an afternoon nap. You can see the mask itself actually slip up and up above the lower lip itself. So this is where the leaks all coming out from. Whereas this another gentleman where there's a beard, his heavy beard has actually caused the leakage from the bottom of the mask. Okay, ignore this slide, all right? Ignore this slide, just concentrate on the video. This is the test that I do, the tube test. Okay, I'll try to play it again and you hear it. See, it's very obvious when he tilts his head down, there's leakage coming out from the bottom of the mask. Yeah. So one of the ways that I can try to help him is to adjust the knob over here. Okay. But overall, actually, he needs a smaller mask. The mask is a bit too big for him. Okay. Okay. Some complications for prolonged usage of masks. Or poor fitting of masks, or the straps are too tight. You can see there's going to be pressure sores, there's going to be frictions or abrasion wounds over the nose, side of the nose. Yeah, very common. And the third picture is patient developed allergy. My own patient developed allergy from, I think, from the latex of the mask itself. Yeah, is it latex or silicone? I can't remember. Yeah, and the solution for it again is proper mask fitting, and all those contact points has to be assessed daily by caretakers, and even patient is him or herself, if the patient is able to do. Try to reduce those mask pressures. And if you are the patient that can actually tolerate two types of masks, for instance, the nasal mask and the oral nasal mask, then you can actually do a mask rotation. For example, this week you use a nasal mask, next week you use an oral nasal mask. Yeah, this will actually help to reduce all this complication. And the last picture is to show the strap that is properly tightened should be able to fit 2-finger breath. Okay, this is a rough estimation of how tight your strap needs to be. Gut issue, that means your stomach or your intestine is always also an issue for patients on NIV. Some patients will come to me complaining that they are bloated after using it, they feel nauseated, they have reflux symptoms, like gastric burning. This is quite common sometimes if your machines are on high setting. Yeah, so some of the air actually goes into it. So okay, about dryness and irritation, I was talking about just now that because our nose actually humidifies air. So patients that uses NIV connecting to your the tracheostomy itself, it bypasses the nose. So the air tends to be very dry. We normally will prescribe an active humidification that I've shown in the circuit itself to try to enhance the humidity of the air. But if it's not done, so you're going to cause a lot of dryness and crusting, and sometimes it can bleed and block the tracheostomy. For patients who are on the mask itself, the face mask or the nasal mask, sometimes if the flow of air is too strong or is connected to supplement the oxygen, okay, this coldness of air, if it's not properly adjusted by the machine, it causes mucus production and it actually blocks the nose of the patient. Some solution is we try to increase the humidity and temperature from the machine. We can actually prescribe them inhalers, nasal inhalers, we call it decongestion or antihistamine nasal inhalers. And there are some saline nasal wash that can sometimes help as well. Okay, maybe 1 or 2 more slides. This is something new for Asia part, telemonitoring. I'm sure all the brands have it. It allows the doctors to, to monitor the results of the patient without the patient, without the hassle of the patient coming to the hospital. So just to show, this is on the picture on the left is a telemonitoring where I sat in with my home care provider on the left. She's doing a mask fitting for the patient. And on the right side is, if you look at, you can see a lot of waveform. That is the report, the sleep or the ventilation report of the patient. I try to figure out, how's the breathing of the patient. And at the bottom, if you follow at the bottom there is the conversation where I have with my patients almost every day. I ask them, how do you feel in the morning? Sometimes because I don't really use sleep lab facilities, and sometimes my patient having problems coming in, they will send me videos of how patients sleep at night. And you can see the last picture there is a so-called modified video to show whether the patient has any abnormal movement when they sleep at night. Okay, so that will be my last slide. Take this opportunity to show that this was a picture taken in our workshop 2 years ago. Dr. Chun, and we were so grateful for Dr. Chun and his team from Singapore. A lot of my old friends have visited and gave a workshop 2 years ago in UMMC. And I'll end with this quote from Nicholas Culpepper. It says that in the past, treating breathlessness, doctor has tried to use licorice boiled in fair water with some maiden laden and fix that makes a good drink for those who have dry cough, hoarseness, wheezing, or short of breath. And I think now we are in the 21st century. I hope that we are not going to use licorice, but for patients, especially ARS, we'll try to consider using non-invasive ventilation instead. Okay, with that, I thank you for your attention. Thank you.